This is a sort of Mahakumbh for all the knee surgeons, and fortunately we are having a PLC surgery as well going on, so probably Dr. Arvind will be able to guide us as we go through the lectures. So starting off with the anatomy, biomechanics and diagnosis. So this is sort of a launch pad for the following presentations. So why is this important? Although not a very common injury, considering other ligamentous injuries that we come across in the knee, probably one is because of that individual solitary PLC injuries are less common. Only about 1/4 of the cases that we see are isolated injuries. It is in combination with other injuries. And more so, the understanding of the PLC has been more recent than the other ligaments. So picking up these injuries has also been difficult for us. Why is it important? It is important because it definitely leads to chronic instability, and two, it leads to failure of our ligament reconstruction surgeries that we do. Supposing we miss a PLC injury and we go ahead with ACL and PCL surgeries, then there are chances that our surgeries would fail because of the PLC injury. So etiology, definitely we know about it, blow to the anteromedial knee in the or hyperextension injuries, knee dislocations as we have in this case which is going on. Of course, we have to be aware of the associated injuries. Common peroneal nerve injury is pretty common with this, so is vascular injuries. Anatomy to this region has always been very perplexing, very esoteric, right from our days of anatomy, where every ligament has a different name. Every ligament has got two names. So, and every structure that is around in this region has been given a common name as posterolateral complex. But we as orthopedic surgeons have a tendency to simplify things. So whatever we can see when we open up, we tend to correlate things according to that. As we can see here, the main three stabilizers in this posterolateral corner is the lateral collateral ligament, the popliteus tendon, and the popliteofibular ligament. These are the main three stabilizers, and at the end of the day, these are the three main structures which you end up repairing or reconstructing in your surgeries. So according to the geometry, this is the arc-shaped structure. The entire arcuate ligament complex, the posterolateral complex, which stabilizes the knee posterolaterally. Of course, there are the other static stabilizers like the lateral capsular thickening, arcuate ligaments. Dynamic structures like the biceps, popliteus muscles. The muscular structures are the dynamic stabilizers. The ligaments are the static stabilizers in this. This again is the layer-wise distribution of the different ligaments that we see. Functions, of course, the popliteus works synergistically with the PCL to control external tibial rotation, varus and posterior tibial translation. So it prevents external rotation, varus and posterior tibial rotation translation. So PLC has to control the external tibia rotation, varus and posterior tibial translation. These are the three properties, whether it's about the diagnosis, the clinical examination, or the repair. These are the three movements which we have to see for external rotation, varus and posterior tibial translation. Diagnosis, of course, history is important, whether it's acute or chronic injuries, the mode of injury, history of previous surgeries, ligament surgeries or fractures. Many a times people would come to you with a ligament, saying that they have a ligament injury, but it probably is a malunited tibia fracture, which is presenting with a varus thrust. There are specific tests, clinical tests to diagnose this, then the concomitant injuries. The varus thrust gate and the varus test is important clinically. The recurvatum test for ACL plus PLC injury. The dial test in 30 degrees and 90 degrees of flexion. The posterior drawer to see for PCL and PLC. The reverse pivot shift. Based on the dial test and the varus test, it is the injury is divided into three parts, but clinically relevant is that if the opening is more than 1 millimeter, then it is grade 3 injury and it needs surgical intervention. Coming to imaging, the stress X-rays and scanograms are important Secondly, there are arcuate fractures which can be picked up on X-rays. MRI, as we can see, the FCL here is avulsed from the femoral component. The biceps femoris being avulsed from the fibular attachment. These photos are courtesy my radiologist friend from my hospital. Here you can see the popliteus muscle being contused, the popliteus and popliteofemoral ligament being avulsed. The popliteofemoral ligament again, the one on the left is normal, one on right is the avulsed part, the arcuate ligament again. Associated bony contusions, be it fibular contusion or anteromedial part of the femur contusions. At the end, we have to understand that it is complex. The anatomy is pretty complex, and we have to understand it so that we can read the X-rays and MRI accordingly. Thank you so much.